Hello, hello, hello. About a week ago, I did a Facebook Live, brought in folks from Zoom, and also it was streamed to Facebook Live, answering some questions about E&M 2021, as well as a short review of E&M 2021. Well, this prompted a couple of questions from Dr. Tom Bates, who asked the question in the Thriving Urology Practice Facebook group. And in this video, I'm going to try to answer those and hopefully stimulate some more conversation and discussion regarding E&M 2021. For those of you who don't know me, my name is John Lin. I'm a urologist here at Sunrise Urology in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group. I know there are a lot of new members, so welcome and feel free to jump in at any time. So the question from Dr. Bates was something like this. John, I was not able to see last Sunday's 2021 E&M review in real time, but did watch it on the replay. Thank you for an outstanding presentation and clarifying the coding based on problem data and risk. Your chart is quite useful. I have two questions. Number one, if those coding criteria are not for hospital and ER patient encounters, that is testis torsion, what are we supposed to use, 1995 or 1997 coding criteria? Well, that's a great question. Actually, for those that are not covered in the office or other outpatient services codes, where we would use the 2021 E&M guidelines, you would revert back to either the 95 or the 97 guidelines. It's as if the new guidelines never took place. You would still use the old criteria to code for those visits, such as you mentioned, hospital and ER patient encounters. So 95 and 97 rules still apply. I think eventually it will change. AMA CPD panel will probably update things so that there will be uniformity across the board, because right now it's too confusing. Can you imagine the auditors trying to figure out which set of rules do we need to use, right? To code and appropriately audit these charts? It will be super confusing. So I think eventually it will happen, but for now, I think they just did a short, slow rollout. The new codes will probably introduce another set of confusion, if you will, because if you look at the 2021 guidelines, that came out in January, they already had to go through a set of technical corrections and updates in March of this year. So can you imagine hospital and other outpatient stuff? It's going to be super confusing if that were to happen. So anyway, Tom has another question that he asked in this post in the Thriving Urology Practice Facebook group. As a pediatric urologist, if I see a patient with bilateral undescended testes, I feel that does fall into the category of, quote, acute/chronic illness or injury that poses a threat to bodily function, end quote. Also, a patient with UPJ obstruction or high-grade reflux or reflux and scarring, or a patient with neurogenic bladder, what do I think? Well, okay, so you're thinking that these presentations, based on what you told me, should be acute/chronic illness or injury that poses a threat to bodily function. So let's dig into a little bit of that definition. That's a level 5 problem that you presented, by the way, that with the acute/chronic illness or injury that poses a threat to bodily function. That's a level 5 problem. We'll discuss whether or not those problems that you presented in pediatric urology are actually level 5 problems. So the definition of acute or chronic that poses a threat to life or bodily function is defined as acute illness with systemic symptoms, acute complicated injury, or chronic illness/injury with exacerbation, progression, or side effects of treatment posing near-term threat to life or bodily function without treatment. Based on what you mentioned here, let's see. Bilateral undescended testis. Is that an acute illness with systemic symptoms, acute complicated injury, or chronic illness/injury with exacerbation, progression, or side effects of treatment posing near-term threat to life or bodily function without treatment? There's always a danger to assume, and I'm going to assume that these patients are coming in to see you electively, brought in most likely by their parental unit, presenting you with this problem. So these are, I'm going to assume, not acute issues that we're going to be dealing with, because this is most likely in the office and other outpatient settings. So I'm going to assume that this is not in a hospital, not through the ER. When these patients present to you, like this little boy with bilateral undescended testis, most likely this boy is not in any acute distress. It was an incidental finding by the pediatrician on physical examination. Oh, maybe this is a little retractile. Maybe this is partially distended and not truly undescended. But whatever the case may be, it's most likely not an acute problem causing harm, potential harm, threat, near-term threat to life or bodily function without treatment. So it's not, I don't think it rises to the level of an acute or chronic problem that poses a threat to life or bodily function in the way that is defined. So what does it most closely follow relative to the problem / complexity? I would say that maybe chronic, stable chronic illness, which is a problem with expected duration of at least a year or until the death of the patient, right? Unless you do something. Chronic conditions treated regardless of stage or severity of changes. Stable is the specific treatment goals for the patient. Unmet, unchanged treatment goals with no short-term threat to life or function are not stable. Risk of morbidity without treatment is significant. So I think undescended testis probably falls more towards the stable chronic illness than an acute or chronic that poses a threat to life or bodily function. Because as the patient presents to you that day, it's probably a stable chronic issue, not a chronic problem that has gotten really bad. For instance, if you see the patient in the ER with torsion or something like that, that would be pretty significant, right? Acute problem with exacerbation, progression, posing near-term threat to life or bodily function without treatment. So that will be torsion. I agree. That will be a level 5 problem. And then depending on the surgery that you do or imaging that you do and discussions, that may dictate a level 4 or a level 5 overall visit. So that, for bilateral undescended testis, the way the patient presents to you, I think that's a level 3 problem, which is a stable chronic illness and not a level 5 problem. So level 3 problem and not a level 5 problem. So let's go on to, what else did you mention? UPJ obstruction. Again, same thing. UPJ obstruction, right? It's most likely, this is most likely it's a congenital problem in the pediatric urology realm. It's most likely a congenital problem. It's one of these issues. It's failure of recanalization after the union of the metanephric blastema and the ureteric bud. So it's a congenital problem. The patient's usually coming to you with an incidental finding on ultrasound with hydrodiphosis on the affected kidney, and patient is most likely walking, talking, or babbling and crawling without any major concern. So this is, again, a chronic, most likely stable problem, or chronic with exacerbation, depending on how the patient's actually presenting to you. Again, I don't want to assume too much. So again, it's a chronic problem, either a level 3 problem, which is a chronic stable, or possibly a level 4 if it's chronic that is worsening with exacerbation. So I don't think it rises to the level of an acute or chronic that poses a threat to life or bodily function if the patient is stable coming to you in an elective fashion as an outpatient. Now, patient can come in really, really sick. That's a totally different situation, in which case it would be possibly a level 5 problem. But most commonly, I would say that it's a level 3 problem or possibly a level 4 problem. And one of the possible level 4 problems is one of the diagnoses that you presented. Let's see, high-grade reflux. Okay, we talked about reflux. Oh, we talked about obstruction. High-grade reflux. Okay, let's talk about high-grade reflux or a patient with reflux and scarring. So high-grade reflux. right? You think the problem is pretty severe, but it's most likely something that's been going on for several months, maybe years, depending on how the patient is presenting to you. Again, it's a chronic problem. And the patient's usually talking, walking, crawling, babbling, however they presented, right? So it's most likely a chronic problem. The question is it chronic that is stable, which will be a level 3 problem, or is it chronic with exacerbation or not a treatment goal, which will be a level 4 problem? In the first scenario, coming into you with reflux, I bet that's probably a chronic stable. But you also said reflux with scarring, right? Reflux with scarring. So now you're possibly saying that this is a chronic problem, not a treatment goal, leading to recurrent infections and then renal scarring. So that is a chronic problem, not a treatment goal. For instance, if this is someone that you put on prophylactic antibiotics and despite that has breakthrough infections and high fevers and comes in with evidence of renal scarring, the patient looks great now in front of you, but there's progression of her disease. So that means it's a chronic problem. Despite the antibiotics that you prescribed, it is not at treatment goal, leading to scarring. So that's a chronic problem with progression or exacerbation, which is a level 4 problem. And if you change antibiotics or if you continue antibiotics or you discontinue antibiotics, depending on after you discuss treatment options, so you undergo prescription drug management. So you have a level 4 problem, which is a chronic with exacerbation, and you have prescription drug management, which is a level 4 risk. So you have a 4 and a 4, irrespective of what else you do, it's a level 4 visit. So I hope that helps. And lastly, you mentioned something about independent interpretation of imaging studies. You always review the studies, and a vast majority of the time you review with the patient or responsible guardian. And actually, I do that quite frequently as well. Directly to the patient, I show the patient what I'm seeing on the actual images, and they often get that aha moment. Oh yeah, the prostate's huge, or the cyst appears to be benign, or the stone, you can show them that the stone is right there in the ureter causing hydronephrosis, but maybe not so much for peds. You would go through the scarring with the patient, even though I find it difficult to explain renal ultrasound to patients because looking at the ultrasound images it's kind of hard. Even with as a medical student or as a new resident, it's hard to understand if you don't have an understanding of the anatomy, the native anatomy, gross anatomy, right? Looking at the ultrasound is going to be pretty tough. But anyway, I digress. Let's get back to this. Let's see. You do not have a financial interest in any imaging center and will see patients that have imaging ordered by the pediatrician and not always performed by pediatric radiologists. The report will say normal testes, but there is evidence of asymmetric testis, which is meaningful. You also have seen where the report stated a lesion is on the right side when it's on the left side, in reversal of measurements stating a testis is 2.4 centimeter when it is 4.2 centimeters. And there's definitely some discrepancy. And if it comes down to, can you trust the imaging studies read by your outside imaging centers? And if you can't, certainly you looking at the images before you take the patients to the operating room is extremely important, right? You correlate the imaging studies with your clinical judgment and your clinical findings and examination findings. If they don't jive, you can doubt the report, doubt the imaging study, or maybe you want to repeat the study. In any case, in this situation, as you described, your independent interpretation of the imaging studies is definitely appropriate, and certainly you would code that appropriately in your data, in the data section. So independent interpretation of tests performed by other professional is a category 2 for a level for moderate complexity data. So that'll be a level 4 by itself, and that's a quick and easy level 4 when it comes to data. And then of course your final E&M level will be driven depending on the problem and the risk. So hopefully that helps. Those are excellent, very insightful questions, Tom, and I'm so glad that you found value in the E&M 2021 review Q&A that we did about a week ago. And for those of you who missed it, I think there's a lot of value in being able to interactively ask questions so that you have your doubts cleared and you have your answers clarified. So you're not doubting yourself. Am I coding correctly? Am I going to be audited and have to be subjected to tape backs with my E&M? So if you're interested in another one of these sessions, I'm happy to do another quick review. And I actually have, I think, 13 or 14 clinical scenarios that I can present. And that always stimulates a lot of discussion regarding your individual practices and the things that you see. I think that's most valuable to you. And if you can't make it to these sessions, or if you feel that you want to attend a seminar, well, guess what? There are 3 free E&M seminars coming up at the end of this month, put on by PRS Network, aka the Painters. Mark Painter will be presenting, I think, 3 or 4 E&M scenarios or E&M presentations that are free coming up at the end of this month, and I'll put that in the video description so that you can click on it and sign up for it. It's absolutely free. So I always say if it's free, I will take 3. If you want a deep dive into not just E&M, but also practice management, how to run your practice more efficiently, improving your revenue cycle management, looking at potential acquisitions with private equity or physician compensation, multitude of other issues that you want to address, there's also the Urology Advanced Coding and Reimbursement Seminar occurring at the end of this year in December in Las Vegas, and also in January in New Orleans. These will be in-person meetings. We already have quite a few people who signed up, according to Scott Painter, who told me that a lot of people have already signed up, and it'll be great. A lot of the learning will obviously be just presentations. You may feel like you're learning and getting information from a fire hose. There's a lot of information to gather. But overall, as you know, those of you who have attended in-person meetings, a lot of the great information comes from the attendees who share what they actually do in their practices, real life situations. And then you think, oh my gosh, I have the same exact scenario in my practice. That's a great piece of information. The networking opportunities are also awesome, on top of the in-person real life situations that is prescribed, and also the solutions prescribed or described by the attendees. So the attendee interaction is amazing. And that's where I learn a lot of information from what actually happens in real life. Anyway, Urology Advanced Coding and Reimbursement Seminar occurring at the end of December this year and 2022, January in New Orleans. Look that up at prsnetwork.com/UACRS. Again, I'll put it in the video description. Let's see. Seeing no comments. All right, I will end this live stream. As usual, any questions or concerns, leave them in the comment section. Take care. Bye-bye.